Welcome to You Are Not Alone, the place for news, tips, and stories of hope for people battling the disease of addiction. My guest today is Dr. Aviva Fohrer from Thalia Medical Center in Haverford. Dr. Fohrer has information on how medically assisted treatment is helping people win their battle with the disease of addiction. Welcome to the show, Doctor, and so happy that you're joining us today. It's a pleasure to have you, so thank you. Dr. Aviva, right?
That's fine.
Okay. Before we get started talking about the medically assisted treatment, can you give us a little bit of background information about yourself and how you got involved with this area of medicine?
Sure. So I came to this from a very non-traditional background. I'm trained as a family physician, and I did my residency in upstate in Pennsylvania at Lancaster. And part of our training in residency was to go to a rehab and spend a month there with a patient as they enter treatment, and then follow them loosely their schedule throughout the month of treatment. And I, in my world, had this like aha moment. And specifically, I was sitting in a group for professionals, and it was a table not like this, you know, not dissimilar to this. And there were all these people sitting around. There was a physician, there was a pilot. I remember there was a lawyer there, and they were talking about their addictions. And the pilot was specifically talking about smoking crack in his car. And I sat there listening to him and knowing what it takes to become a pilot, and knowing what people risk when they struggle with substance use. And I just had this realization that this is really what I want to do. In addition to that, during my last 2 years of residency, I had the opportunity to be a program director at a small methadone clinic and start a Suboxone program. And so I started working as an addiction doctor while I was still training to be a family medicine doctor.
Wow. One point you made is profound about a pilot who was struggling. Absolutely. And how, you know, it just highlights how nobody is immune from this horrible disease. So it wasn't only, you know, it's just not our stereotypical look at what somebody is struggling with, but that it knows no boundaries.
That's exactly.
Wow.
That's exactly how I say it.
That's amazing. That's great. So talk to us a little bit about, I don't know a whole lot about medically assisted treatment, so maybe you can take some time and just enlighten us, as, you know, for people who don't have any idea what medically assisted treatment is.
Sure, definitely.
Thanks.
So I'll say MAT. It's just a little quicker. So medically assisted treatment, MAT, involves what you would think of as medication for the disease of addiction for those who are struggling, but it's really much more than that. Full treatment is a whole, and I'll go through it in details later, but it is a whole gamut of individual therapy, medication, and then support. The medication part of it is basically the idea of, I'll use an example of like diabetes, of giving someone a medicine that helps them with their disease, that allows them then to really engage in being, living a healthier life overall. So in my world, we don't have a lot of choices with what medicines are out there. Suboxone is what most people have heard of. That's also called buprenorphine. That's its the other name for the medicine. And it works by binding in the receptors in the brain that opiates bind to. So we naturally have opiates, right? When you exercise or you eat something really good or you see someone you love, your body makes opiates, endorphins, right? They bind to those receptors. So the way this particular medicine works is it binds to the opiate receptors. It stops cravings, but it also allows people then to go about learning how to live a sober life. There's another class of medications which bind to those same receptors, and it neither turns the receptor on like an opiate and doesn't turn it off. It just binds it and blocks it. So I don't want to go to you said not to get too specific. So agonist and antagonist, but basically what it does is it binds to the receptor and doesn't allow the receptor to be turned on and the receptor to be turned off. And Vivitrol or naltrexone is an example of that.
Okay. Very good. Yeah, I think that's a pretty good explanation of it. So you mentioned Suboxone and Vivitrol. Can you talk a little bit more about how how those maybe are administered or how they work, or what's their form?
Great. So that's a really good question, because up until not that long ago, a couple years ago, we really had oral for the, I like to use buprenorphine because there's actually a couple other companies that also produce Suboxone. The brand name Suboxone, sort of like Coca-Cola. Correct. Okay. So I use buprenorphine just because it's kind of levels the playing field for what's out there.
Sure.
Up until a few years ago, the oral formulation was the only one that we had on the market. There was a couple of other companies that came out with an implantable rod that didn't really take off as much, but 2 years ago, 3 years ago now, 2017, the injectable form came out, and it's a 1-month injectable. And the reason, there's a reason I'm pointing this out. It's very important to me as far as shifting our whole paradigm of how recovery treatment is. So up until 3 years ago, it was an oral medication. And if you think about what's going on when somebody's active in addiction with opiates, is they're getting this daily reward, sometimes 3-4 times a day. If they're shooting up, same thing, right? They're getting this reward. So craving, withdrawal, I get the reward and the relief from my suffering 2, 3, 4 times a day. If I give you an injectable, same medicine, does the same thing, you now have to sit with your discomfort. You now have to sit with what's going on up here for a month.
Oh, it's a month.
It's a month.
Okay, it's a
and
month
so it's
treatment.
a very different, well, the medicine part is the treatment that's different. So it's a very different way to go about having treatment when you have an injection that lasts for a month and the medicine is in you for a month.
Okay.
And it then really gives you the space to do all the other work, which we'll talk about in a little bit, but all the other work as far as recovery.
Okay.
So to answer your question, the buprenorphine or Suboxone had always been oral. More recently, we've started with injections. It's called Sublocade. The Vivitrol, which works a little differently than the buprenorphine or the Suboxone, has always come in both the oral and the injectable forms, and still is a very valid way to think about shifting from a daily, taking something every day, to a once a month. And so I really like to try to encourage people to think about getting the 1 month.
So the 2 medications that are available now, Vivitrol, and I'm going to say Suboxone, but say the term again. I know it takes a little while to get used to.
Buprenorphine.
Buprenorphine. Okay, yes. Buprenorphine and Vivitrol. Are they used to for the same drugs? In other words, for opiates or heroin, or are there other things that they address, inhibit, or
good question.
block?
So I'll start with the Vivitrol or naltrexone. So that's approved, FDA approved for both alcohol abuse disorder and opiate use disorder. And I use them interchangeably for both. They're very effective. Oral naltrexone or Vivitrol with Wellbutrin, actually, which is it's an antidepressant, is also used for binge eating disorder. So frequently I will see people that have other addictions, not just substances. So food, eating, gambling, sex and love addiction. And so sometimes we can use these medications.
Really?
Yeah, it's kind of interesting.
Wow.
And they have like a 2-for-1 or a 3-for-1. It's nice, right? Because I don't have a huge armament of tools to work with in my world. So the Vivitrol or the naltrexone is used for alcohol and opiates, also for binge eating disorder. The buprenorphine or the Suboxone is only for opiate use disorder. So I don't have, there's a couple other medications for alcohol that I do have, but these would probably be the 2 that I use the most commonly.
Okay, and what is there anything that is used in the case with cocaine use? As we know, we're hearing about it. It's unfortunately making its way back. Everything kind of comes around in this terrible state with this addiction. So, I mean, is there anything that is being used in that area of addiction, cocaine? We
don't have anything that's FDA approved, but off-label there are some medications that are out there. Topamax is one of the ones that I'll use.
What do you mean off-label? I'm sorry.
So the FDA approves. It's a very long process to get any kind of medication approved in our country and then used for a specific disease. Okay. And then they put that on label. So they say this medication, buprenorphine, is used for opiate use disorder.
Okay.
Frequently, especially in fields that are emerging and constantly evolving, and addiction is certainly one of those fields, we do a lot of things that are off-label, meaning we're using them not for what the FDA has approved it for, but that we have found collectively, the medical community as a whole have collectively found it to be useful and works.
Okay.
And then we start generating the data that way. Enough people talk about it, there's enough movement that goes in that direction, and then they say, okay, let's do some studies and let's see if we can get it approved. You see that a lot in cancer treatment. You'll see that, you know, some of those other areas of medicine. So off-label, we'll use a lot of medications.
We didn't talk about this sooner, but it kind of brings up the idea in my mind is about what about medical marijuana? Is it being used in treatment? I mean, I don't know.
No,
I'm just wondering for, you know, for information's sake. I don't have a position one way or another on it, but it's here. I mean, there's a clinic, a medical marijuana facility out where I live in Westchester. Dispensary, yes.
Correct.
And I'm just wondering, is that something else that the addiction community is looking at, or specifically doctors maybe and some doctors aren't? I mean, I know we didn't talk about this early on.
No, it's good. I'm glad you're asking.
I'm just curious.
This is also ever evolving. So I do prescribe. I'm a prescriber for medical marijuana. I walk that line very carefully, and I think about it very carefully before I will prescribe for someone, and it has to be in the context of a bigger picture of what treatment is for them, not just that. That being said, there's a lot of gray area with it. There aren't enough studies that have been done. There aren't enough long-term studies that have been done. I will say this. My personal philosophy about this is, in many ways, it's a slippery slope that we need to be very careful about walking down. One of the things I talk a lot about with my patients is up until the age of 25, the brain is growing and developing. We call it neuroplasticity, right? You know that. So when we expose anyone under the age of 25 to any substances, it's very easy for the brain to be affected much more profoundly than after the age of 25. The marijuana that's available today is not the marijuana that was available when I was
talked about it. You're absolutely right. You're so right.
You know, the THC levels are much higher.
Very dangerous.
It has a more profound impact on the brain. And so if you're asking me, you know, Dr. Aviva, like, what do you think about marijuana for anxiety or for insomnia in a 40-year-old person who's also in early recovery? I would have a very different answer than if you said, what do you think about a 20-year-old who's getting into recovery and using that for anxiety? So I'm going to say there's a place at the table for it. I think we just have a long way to go, and this pendulum is swinging a little too quickly. That's my feeling.
I agree. I would have to agree with you on that. So as far as administering these medical treatments, what's happening in the recovery, like inpatient recovery and outpatient recovery and maybe recovery homes? How and when are these medications being used?
It's a good question, right? It's a great question.
How do we integrate them into the full picture here?
So I just mentioned the pendulum swinging, right? And how we view things, and how my field is in so many ways such a rapidly developing and changing field of medicine. MAT, medication-assisted treatment, was not so much the standard of care while people were in patient and then on discharge from patient. Most people, when they would go to outpatient, which is the level of care that I do, you know, you come see me in my office, most people would then start MAT. This has definitely changed. So now many more treatment facilities, when you go inpatient, will maintain you on MAT or start you on MAT and then discharge you and have you follow up with a provider that will continue it. And the example I give is like insulin. You know, if you go to the hospital for a heart attack, right, and you've been on insulin for your diabetes, they wouldn't stop your insulin while you're managing your heart attack, right, and managing your cardiac disease, and then send you up back on your insulin. They would maintain you on the insulin while they're dealing with the acute problem. So people would sometimes come to an inpatient facility for, let's say, alcohol, but they had a history of opiate use disorder, or cocaine, right? Or marijuana, and they had opiate use disorder, and they were on it. Traditionally, what would happen was they would be detoxed off their buprenorphine or their Suboxone. They would have whatever they're there for, the acute situation, and substance managed, and then they would be sent out. from a brain neuroplasticity standpoint, back to that, it was really difficult for people to maintain their sobriety. So now we know that if you're on Vivitrol, you stay on Vivitrol. If you're on buprenorphine, you stay on buprenorphine and deal with whatever else they're inpatient.
Okay.
Does that make sense?
Sure. So is there, I mean, so I understand, is there like a place where there's a detox? Like if somebody comes in, you know, pardon me, abusing opioids or alcohol, does the facilities generally do they typically do like a 3 to 5 day detox and then start these medications? Or is it like you're saying that they're coming in, they want the treatment, and you're just administering these medications as soon as they enter rehab? Like, give me an idea, because I mean, withdrawal can be very difficult, as we well know.
Right, and even dangerous.
Very dangerous. We've talked about that on the show.
Right. Yeah. Alcohol and benzodiazepines, you don't ever want to stop.
Stop.
You have
cold
to be
turkey.
You have to be tapered off of that. And you can taper inpatient or outpatient. I do outpatient taper, so I could do outpatient alcohol, outpatient benzodiazepine. If they go inpatient and they taper off of it, traditionally what they would do is have them be there for 30 days or however long the insurance company will pay for, right?
That's it.
And then they would, at some point before they left, start them on whatever medication part of treatment, the MAT part of treatment, and then send them for follow-up as an outpatient. Now what they're doing is, I'm seeing a lot more of this, is whatever the substances that the person's coming in on, their detox tapered off of that anywhere from 3 to 5 days. And then the medication treatment is started at some point during the 3 weeks, because cravings start coming in, and it would be very hard for someone to engage in the work of recovery, to engage in treatment, if their mind is spinning so much in cravings. So buprenorphine is an incredible medication for that, to quiet down that noise and then really let you be present and do the work that needs to be done while you're inpatient.
Do you see more of that now with these medically assisted treatments? You see more of them being used while people are inpatient.
Yeah, and a lot more injectables.
Okay.
Which is really, it's amazing. It's a change that's needed to come, and it's a long time in coming.
And then, so if somebody has this regimen during their inpatient stay, okay, their 28 days is up, and they go out either home, or maybe they go to a recovery community.
Sure.
What happens then? You know, they're out in society again, at whatever level or whatever place or space they're in. Do the recovery homes welcome, generally speaking, I don't know, do they welcome this medically assisted treatment protocol?
That's a great one. So there's also a shift that's happening now.
Okay.
Which is that more recovery homes are being more open to people being on medication-assisted treatment.
Okay.
And if we go back to what we were talking about earlier with taking something orally, understandably, if you have a house full of people in early recovery, it makes sense that you would be concerned about having a medication that could be abused, misused, diverted. Right. And that's always been the standard concern, is we don't want abuse, misuse, or diversion. So to answer your question, up until recently, it has been very difficult to find people housing in a recovery community that allows MAT.
Really?
With some government changes, there's been some state changes too. More and more housing is becoming more open to that. My sense, again, is once we push more for the injectable form as opposed to the oral form, that's going to happen quicker, because I don't have to worry, or you don't have to worry about me diverting my medication or misusing or abusing it if it's an injection. You know that I have it, you know I'm compliant with it. Because it all comes down to patient safety. I don't want someone to die. You know, they finally got to the point where they sought treatment. They finally got to the point where they're following up. We want to make sure people are safe.
Absolutely, absolutely. So so if they're going into a recovery community and these injectables are being used, of course then they get tested. They get urine tests every couple of days. If they know that is present prior to, that's very transparent, then there shouldn't be any problem typically with the recovery home.
You would think so. It's still been a slow-moving needle.
Is it? Really?
Can't answer it, but it is changing.
Okay.
It is.
Well, that's good to hear. I'm glad to hear that. So let me ask you this. When it comes to these injectables, these medications, Is there a time frame, a recommended time frame that these individuals stay on this? Do they taper off? Is it a lifetime? I know, I'll just speak from my own experience. Our son Nicholas did have an experience with Vivitrol, and unfortunately it didn't, stop his issue with addiction.
Right.
I'm sure it's wonderful that these medications are working, but is there a time frame? Are we speaking of a time frame here?
So yeah, there definitely is. Back to the brain and the neuroplasticity. We know it takes about 12 to 18 months to make changes that are more permanent in the brain when someone's active in addiction. So 12 months is about the amount of time I would usually recommend somebody being on any type of MAT. And the idea is, we kind of glossed over this earlier, but I want to emphasize the idea is you're not just being handed a medicine. You're not just being given a medicine, right?
Right.
The assumption is there's a whole network, a frame that's built up around you while you're learning how to live a sober life. And that includes one-on-one therapy, right? That includes taking care of any other issues you might have, like depression or anxiety, right? Insomnia.
There's a lot of co-occurring.
So much co-occurring, correct.
Right.
It means having a support team around you, right? Who's your family and in your circle. And I'm a big believer in also a community support. It takes a village.
Absolutely.
So that can take the form of 12-step, which is easy to find and plentiful. It can take the form of SMART, like a different kind of sober recovery, SMART recovery. It can take the form of your church or synagogue or mosque. You need all of those pieces in place in order to really learn how to live a sober life.
Sure.
My philosophy is everybody should have an attempt at tapering off of or stopping MAT. I think that we don't give enough people credit for how strong they are.
Right.
And it's frequently difficult for both the provider and the person to taper off. That's something that I actually love to do. I do. I find it's very gratifying to give you the strength and help you find your skills. To be off of all of MAT. That being said, I have people that have been on medicine for years, and we've done a trial, and either they've relapsed or they haven't done well, or they felt that they weren't able to. And I really believe in meeting people where they are. It takes so much courage.
Sure, it does.
Just to do this.
Absolutely.
That I'm not either complete abstinence or stay on MAT.
Right. Yeah, I think that I think I do recall hearing, like, with at least the naloxone was like a 12 to 18 month period, and they when I was exposed to it, they like to kind of get people tapering off of it, like you're saying, to peel back another layer.
That's how I look at it.
Find your true self without medications.
Right. And think about it again. If we go back to medicine, think about diabetes. So if you came to me and you were overweight, smoked cigarettes, had high blood pressure and diabetes, I would do everything I needed to do to help control your diabetes, right? I would say, like, let's work on your smoking, let's work on exercise, mindfulness, meditation, all of that. At some point, I would give you a trial of going off of whatever medications you were on. Either you can do it or you don't. Your pancreas either makes the insulin or it doesn't. We're talking about dopamine in the brain, and it's a very complex system.
Absolutely.
Some people literally have made the changes in their brain that we can't rewire it.
Right.
And if that's the case, there is no reason to take them off of a medicine if they've got a healthy, relationships, if they're working, all of that. I don't see any reason to.
Yeah. So it's just one piece to a complex puzzle of getting people through, the addiction and recovery process. How about its affordability? Is there affordability? I mean, these medications being a 30-day injectable, how are insurance companies approaching this? We all have the best intentions, and I just wonder, is this an affordable treatment across the board for people? I know. Go ahead, medicate.
Yeah, it actually depends on your insurance, and there's a variety of coverages. There's supposed to be parity with MAT, which means that all MAT medications should have equal coverage as with any other chronic disease, which is true on paper. The actual logistics of doing that is a little more difficult. The injectable, the newer medication, really is quite expensive, and paying out of pocket is sometimes the quickest way to get someone the treatment. Although very, very costly. The oral medications are a lot more affordable and covered today. And I've seen this swing over my 12 years of doing this. 10 years ago, it was very difficult to even get the oral medications covered. It was a long process. Now, almost there's enough generics, and every insurance company covers it. Sometimes there's a few more hoops to jump through than others. For the injectable, that's still the buprenorphine injectable. We're still working on that. It does take a little more time, and it is expensive. But what I always say to people is, how much money were you spending when you were drinking, smoking, using?
Right, that's
you
true.
Know,
it's true.
It's if you're gonna do a cost-benefit analysis, it always is cheaper to go into treatment.
Right, but what was their lifestyle?
Absolutely.
How were they generating funds?
Right.
Unfortunately, to feed their addiction. So, is there any data? You know, in closing, I'll ask you: is there any data to the success of these assisted treatments at this time? Is there any data that comes across your desk, or data you keep maybe?
So I get asked this a lot with MAT and just addiction treatment in general. Like, what's your outcomes? How successful are you? Is what some people will ask me. It depends on what you define as success. So to me, it would be: are you living a lifestyle that's free of substances? Are you engaged in healthy relationships with people around you? Are you in a place where you're able to be a productive member of society to the best of your capacities? And if you can say yes to all of those, it's success. And the thing that I really emphasize with people is success isn't measured in terms of what's in my urine and whether I'm using or not.
Right, exactly.
Because back to diabetes, like, I don't know if you know anyone with diabetes, but they eat cake every once in a while. And they'll have Ben and Jerry's every once in a while.
Little sugar creeps in.
They're not failures, right?
No.
Yet we really look at addiction medicine as a failure if you, it's a linear. And so I really try to look at it as it's a circuitous thing. This is recovery. You're going in this direction as opposed to this direction.
Exactly. Wonderful. That's fabulous. Well, it's been extremely enlightening and very helpful for people to hear this information, and I thank you so much for coming on and talking about this. So if people wanted to connect with you or find out more information, how to get in touch with you, how would they access you?
So I have a website. Thalia Medical Center is the name of our practice, and it's www.thaliamedical.com, or look up Dr. Aviva. Pretty easy to find me.
Fabulous. Very good. Thank you so much. I really appreciate you coming in today.
Thank you for having me, Brenda.
And thank you for joining us for this important discussion. I'm Brenda Schivito, and remember that you are not alone in the battle against the disease of addiction. If you or a loved one need help or would like to make a donation, visit us anytime at angelsagainstaddiction.org. I believe that together we can save lives. Thank you.